Welcome back to the deep dive. Okay, let's jump straight in. If you're prepping for the MSRA, this one's definitely for you. We're doing a proper deep dive today on something you are absolutely going to come across, Milia.
Hmm.
We've gone through the clinical material, the key sources, and basically our mission is simple. Pull out all the crucial high-yield stuff you need for your revision, what it is, why it happens, what it looks like, and how you manage it. Make it stick.
Yeah, exactly. And Milia, they might seem quite small, maybe insignificant, but they're really common. Plus, crucially, you need to know the differential diagnoses. Being sharp on those for the MSRA is what's key for spotting the right answer in those clinical vignettes.
Totally agree. Okay, so let's start at the beginning. What exactly are Milia?
Right, so fundamentally, they're tiny, benign cysts, little pockets under the skin.
And when you see them, they're those classic tiny white bumps, right? Sometimes a bit yellowish.
Spot on, white or yellowish bumps. And inside that little pocket, it's keratin.
Ah, keratin, that protein the skin makes.
Yeah, exactly. It just gets trapped beneath the very top layer of the skin. That's what forms the bump.
And location-wise, we often see them, well, the face is pretty common, isn't it? Especially around the eyes, the nose.
Definitely common spots. But yeah, they can appear elsewhere too, which we'll probably get into.
Okay, so we know what they are, these little keratin-filled cysts. But why do they actually form? What causes them?
That's the million-dollar question sometimes. The exact trigger, well, it isn't always perfectly clear. But we definitely know several factors that contribute.
Right, it's not just one single cause then.
Yeah.
What kind of things are we talking about?
Things like skin trauma. That could be from an injury, maybe even certain skin treatments. Blocked sweat ducts sometimes play a role.
Okay.
Also, some underlying skin conditions are associated with them. And prolonged sun exposure is another factor mentioned.
Interesting. So knowing those contributing factors, who's actually more likely to get them? What are the main risk factors we need to keep in mind?
Good question. Risk factors are definitely high yield. Top of the list probably is newborns. Neonatal milia are extremely common.
Extremely common, yeah. I think we've got a stat on that coming up. Who else?
Well, besides newborns, people with certain existing skin conditions, particularly blistering disorders.
Right.
Also, anyone with a history of skin trauma, like burns or significant abrasions.
Makes sense, linking back to the causes.
Exactly.
Huh.
And long-term heavy sun exposure is a risk factor too. Oh, and one more, using really heavy occlusive skincare products. Things that might block the pores or the skin surface.
Right, those thick creams sometimes. Okay, that gives us a good picture of who's at risk. Now, you mentioned the keratin trapping. Can we dig a bit deeper into the pathophysiology, what's actually happening under the skin?
Yeah, absolutely. So it really boils down to how the skin runes itself. Normally, dead skin cells just flake off the surface, right? Exfoliation.
Mm-hmm.
With milia, that process kind of goes wrong. Instead of shedding properly, some of those dead skin cells get trapped just beneath the surface.
Okay, so they don't make it all the way out.
Precisely. They get stuck, forming this tiny pocket or cyst, and then that keratin protein we mentioned earlier builds up inside that pocket. That's what makes the firm little white bump you see.
So maybe like a tiny traffic jam for skin cells just under the surface. They get stuck, pile up with keratin.
That's a pretty good analogy, actually. Yeah. Little keratin traffic jam.
Okay, analogy locked in. Now, this next bit is critical, especially for exams. You see a small white or yellow bump, maybe on the face. What else could it be? We need that list of differential diagnoses.
Absolutely crucial. You've got to have these in your head. The key ones to consider are things like acne vulgaris,
Right, common one.
syringomas, xanthelasma, especially around the eyes, trichoepithelioma, and follicular mucinosis, sometimes called alopecia mucinosis.
Okay, that's a solid list. And you mentioned one earlier that's particularly important not to miss, especially in certain groups.
Yes, basal cell carcinoma. Particularly in, say, older individuals with sun damage, if a lesion looks a bit unusual or is new, you must keep BCC on your radar. We'll touch on why that's relevant when we talk about investigations.
Got it. So any quick tips to tell milia apart from, say, acne or xanthelasma just by looking?
Well, yeah, there are clues. Milia are typically very small, 1 to 2 millimeters, smooth, distinct little domes. Acne usually involves a pore, inflammation, maybe pustules or comedones. Xanthelasma are usually flatter, softer, yellowish plaques, often on the eyelids. Syringomas tend to be small, skin-colored or yellowish bumps, often clustered, again, common on lower eyelids. Knowing that classic milia look is step one.
Helpful distinctions. Okay, let's talk numbers briefly. Epidemiology. Who gets Milia, and just how common is it?
It affects pretty much everyone, all ages. Infants, children, adolescents, adults.
Yeah.
We see them commonly across all those groups. But that newborn statistic really stands out,
Yeah, what was that again?
about 50%. Half of all infants either have them at birth or develop them shortly after. Congenital Milia. So, yeah, if you see them on a baby, Milia should be right at the top of your thoughts.
Wow, 50%. That's huge. The material did mention, though, that specific UK-wide data for other age groups is a bit limited.
That's right. Beyond that infant figure, detailed UK stats aren't readily available in the common sources.
Okay. Let's paint a picture then. Clinical features. If you're looking at someone, or maybe an exam photo, what are the key things describing Milia?
You're looking for small, firm, raised bumps, usually white or yellow. They typically have a very smooth, sort of dome-shaped surface.
And size. Pretty small, right?
Yeah, tiny. Generally just 1 to 2 millimeters across. And symptom-wise.
Mostly asymptomatic, aren't they? Usually painless.
Correct. Generally no symptoms at all, unless perhaps they get inflamed or infected, which is uncommon. Sometimes people might report mild itching, but usually nothing.
And locations we mentioned: face, eyelids, cheeks. But you also flagged they can sometimes appear elsewhere.
Yes, the genitalia is another location mentioned. Less common than the face, but definitely something to be aware of, especially for, an exam scenario question. Could trip you up if you only think face.
Good point. Now, the sources also break Milia down into different types. This seems really important for the MSRA, as the presentation isn't always identical.
Absolutely. Knowing the types helps understand the context. So let's run through them. First up is primary Milia.
Okay.
This is the most common type we see, often in infants, typically on the face, scalp, upper trunk. They can be there right at birth or just pop up spontaneously later on. Yeah, standard kind.
Got it. Next.
Milia on plaque. This one looks different. You see the small milia papules, but they're clustered together on a distinct reddish, maybe slightly raised area, a plaque.
Okay, so Milia on a plaque. Where does that usually show up?
Often behind the ears. That's
Oh.
classic spot. But also eyelids, cheeks, the jaw area. And interestingly, this type is seen mostly in middle-aged women and can sometimes be linked with other skin conditions.
Right. So, exam vignette. Middle-aged woman, reddish, bumpy plaque behind the ear. Think Milia on plaque. That pattern and demographic is the giveaway.
Precisely. Then you have multiple eruptive milia. The name kind of says it all. You get crops of milia appearing, sometimes quite suddenly over weeks or months.
Where do those tend to erupt?
Common sites are the face, upper arms, and the upper trunk. Just lots of them appearing relatively quickly.
Okay. And the last type,
That's secondary milia. These aren't spontaneous. They happen because of something else.
like the risk factors we mentioned.
Exactly. Triggered by another skin disease, maybe certain medications or trauma like a burn, dermabrasion, that sort of thing.
Mm-hmm.
And because they're secondary, they can pop up anywhere on the body depending on what caused them.
It's a super useful breakdown. Primary, plaque, eruptive, secondary. Okay. So you see something that looks like Milia. Do you always need to investigate? Run tests?
Often, no. For your typical straightforward milia, the diagnosis is usually clinical, based on how they look and the patient's history. Simple cases generally don't need further tests.
But there are always buts in medicine, especially for exams. When do you need to dig deeper?
Right. The sources highlight a couple of key situations where you should consider investigating further. Firstly, in elderly people, especially if they have a lot of sun damage.
Why specifically that group?
In that context, you might consider a biopsy to rule out something called nodular elastosis of the skin, or Favre-Couchot syndrome. It can present with cysts and comedones and sun-damaged skin, so you need to be sure.
Okay, so elderly, sun-damaged skin, unusual bumps. Think biopsy to rule out Favre-Couchot. What's the second scenario?
The second is if you suspect milia en plaque. Remember, that distinct presentation on a reddish plaque.
Yeah.
A biopsy is often recommended there too, just to confirm that specific diagnosis and make sure it's not mimicking something else. So it comes back to being sure about your diagnosis in less typical presentations.
Makes sense. So recap. Simple Milia, clinical diagnosis. Elderly plus sun damage OR, suspected Milia on plaque, consider biopsy. That's a clear action point.
Exactly. Okay, let's talk management, particularly from a UK perspective. What do you actually do about them?
Well, the first and probably most important point is that they often just go away on their own. Spontaneous resolution is common, especially in babies. So often the first step is just observation, watchful waiting.
True. But if they don't go away, or if they're very widespread, or if they're really bothering the patient cosmetically, then yes, treatment options exist. But these should really be done by a qualified healthcare professional, not home remedies.
Definitely. What are the main professional options listed?
Several are mentioned. Dermatologist extraction is common, using sterile tools, like a needle or blade, to nick the surface and express the little keratin plug. Apparently, they often shell out quite easily.
Shell out easily, okay. Sometimes without anesthetic even.
Sometimes, yes, as they're very superficial. Other options include things like chemical peels, microdermabrasion.
And topical retinoids were also mentioned, right?
Yes, topical retinoids are another tool in the box.
Now, really important what doesn't work. Something to advise patients against trying.
Yes, crucial point. Topical peeling agents, like your standard over-the-counter salicylic acid washes or creams, are specifically mentioned as not being effective for Milia. They work differently than for acne.
Right, so tell patients not to bother with those for Milia. So a quick memory aid for the effective professional treatments. Maybe think things that physically remove or unroof the cyst.
Yeah, that works. Think EPMR extraction, peels, microdermabrasion, retinoids, procedures that target the cyst or the top skin layer.
EPMR, nice. Okay, what about the overall outlook? Prognosis.
Generally really good. Milia are harmless, fundamentally. The main issue is cosmetic appearance, and as we said, they often resolve spontaneously over time.
Any chance of them coming back?
Yes, the possibility of recurrence or new ones forming is mentioned, so clearing them once doesn't guarantee they won't pop up again.
And for babies, that 50% who get them.
Prognosis is excellent there. Those congenital milia usually vanish within a few weeks of birth. No intervention needed typically. And just linking back, remember the referral point. Consider referring if you suspect milia on plaque for that diagnostic confirmation.
Got it. Last section then, complications. Are there any potential downsides or problems associated with Milia?
Thankfully, if you just leave them alone, milia typically don't cause any complications. They're benign little things.
So the problems come if people try to interfere.
Exactly. The main risk is if someone tries to squeeze, pop, or pick at them at home. That can introduce bacteria, leading to inflammation or even infection.
And messing with them improperly could cause other issues too.
Yes, definitely.
Yeah.
Trying to dig them out incorrectly could potentially lead to scarring or changes in skin pigmentation in that area. So the advice is always leave them alone or see a professional for removal. Don't DIY.
Right. Wow, okay, that was a proper deep dive. We've gone from the definition, those little trapped keratin cysts, right through to appearance, the different types like primary versus secondary versus plaque, the risk factors when you do need to investigate, and the professional management options. All the key stuff for MSRA prep pulled from the sources.
Yeah, I think the absolute must-knows are telling the difference between the types, especially recognizing milia on plaque, having those differential diagnoses locked down, including when to think about BCC, and knowing the specific times a biopsy is warranted. Those are classic exam fodder areas.
Definitely. And remembering that while they might look simple, knowing these details helps you diagnose correctly, avoid missing something else, and advise patients properly on whether to treat or just observe.
So here's a final thought for you to mull over as you revise this. We know spontaneous resolution is common, especially for infants. Based on everything we've discussed, what are the key factors or clinical scenarios that would really push you to actively recommend treatment, rather than just watching and waiting? Think about patient impact, cosmetic concern, and the specific milia types.
Great question to ponder. Okay, that wraps up our deep dive on Milia. Hopefully that's made your revision on this topic concise, clear, and really impactful.
And for more free MSRA revision resources, do check out freemsra.com.
And if you're looking for the full premium revision toolkit, head over to passthemsr.com.